Right, good morning. How are you doing? So lots of really exciting stuff. Damien comes up here, 2 billion project, I'm going to get the money, you know, we're going to go forward, we're going to put EHRs into the whole country. And then Tim recently, his office is down the corridor from me, says, we think we'll run this this session around the academic officers and we'll talk about the research and all the benefits. And I said, that's great, Tim. What about getting this thing in? Right? It's just a little thing, you know, it's not that easy to put these things in. So what I'm going to really talk about is kind of some of the 11 steps to nirvana, really, in trying to getting an EHR in. And many of you have done it in terms of very, very eloquently talked about it. So in terms of our work in CHI, yes, we're putting in an EHR, and everyone knows about that, and we're opening a digital hospital. And some people don't know about that, but they all know about the price of the hospital. And in doing that, I think people often forget, you know, I used the analogy yesterday at an internal session that this is a bit like an armada, you know, in terms of a naval armada. The EHR is definitely the aircraft carrier, but it needs lots of stuff around it to make it happen. Okay, so the first thing you need, the right team. And the team is not small, and you know, Dermot has alluded to that. In CHI, we have about 106 people specifically to implement the EHR. And that's a lot of people when you think about it. So if you think you're just going to get somebody who's going to rock up with a disk from whoever the vendor is and put that in there, log it up there, you'll be grand, right? It doesn't work like that, and you need to go through the whole configuration, and it takes time, and as I said, that's already been alluded to. You need to have people on your team who've done this before, and there's not many in this country who have done it before. Okay, this is not the same as putting in an ED system in one specialty or wherever, you know. It is much bigger than that. So you need to get people who've done it before. If you touch any of these, I'll lynch you, right? So that's a threat. And I have a second-degree black belt now many years ago when I was a bit more mobile. The second thing is you need a CXIO team, what we call a CXIO team. These are our clinical champions who act as the interface between the program and our end users. So we have a Chief Medical Information Officer, Nursing Information Officer, HSEP Information Officer, and Pharmacy. We're missing two, I think, really here. One is around the academics and the operations one. We've solved the operations one. She's just not with us just yet, but on the way. Okay, so that's really essential. You need to engage your hospital teams, and you need to know what you're installing, what you've bought, and what it takes to actually get this thing in. And then, therefore, you need to know, you know, what is it going to do for my patient? What's it going to do for my staff? You know, you need to be able to articulate this. You need a comms program around this. You need to really be able to tell it simply what changes are going to make me, you know, for me in my daily work. And the EHR can make, you know, rapid and major changes in terms of how people deliver their work, but you need to be able to contextualize that for them to get them engaged in the process to help you design the system. We have a fairly large scope for our EHR. Very thankful to the taxpayer. Thank you very much, and thankful to be fair, to colleagues in the HSE and the department who supported us in getting this. We're putting many modules in. We're actually replacing lots of modules that we currently have. So we would have an ED system, we have an ICU system, we have a laboratory system. They're all going. Yeah, we're getting rid of them and we're putting in a brand new one. And that sounds kind of a bit daft, but actually if you talk to colleagues around the world, the biggest issue is trying to get data to flow from one system to the other, and Margot eloquently talked about that earlier. This is an interesting slide from class from a number of years ago, an organisation, and they looked at the satisfaction of EHRs from end users, right? And it ranges, you can see, from 20% up to nearly 100% satisfaction with their EHR. The really interesting thing about this graph is these two ones, Hospital A and Hospital B, are the same system. Okay, so it's nothing to do with the system. All the systems are really good. Some are slightly better than others, but they're all really good and they do good jobs. So it's how you implement this and how you train your users really impact on that. You need the right infrastructure at the back end and the right end user devices. Damien spoke about this in terms of the Wi-Fi. Some hospitals have nothing, really poor Wi-Fi. If you have poor Wi-Fi, you're not going to implement an EHR. Why? Because it won't run, it'll be slow to load, it'll take time, people will get really fed up with it, and they'll blame the system. right? The system is more than that. It is everything that lies underneath this. So you need to worry about your network, your servers, and your end-user computing. And it's all this sort of stuff you need to go through. What do I need? What does an end user need to actually communicate with an EHR? We forget about that. We all think about buying the system and it's lovely and it's going to do all these great things and we're going to get research and it's going to run our clinical trials. It is if we get the data in and people can use it. Yeah. So how we allow our users to communicate and connect to the system is really important. We've gone through a huge process in trying to identify this. At the end of the day, we're now kind of looking, you can see some of the numbers here, 1,000 barcode scanners, 2,500 PCs, 358 WOWs, workstations on wheels. These are big numbers. And and if you don't have these today in your hospital, these are the sort of things you're going to have to worry about in terms of how to get them in, how to connect them, and then how to test them. We've gone through a process of literally going through every single room and saying, what do I need in where? Interesting lesson. When we started this process, everybody said, oh, I need a fixed PC in every room. That's it. That's exactly what I need. When you go through the process and you talk to colleagues and you get people experience, they change that view completely. So what you start with is very different from what you actually end up with. And I suspect we haven't even got it 100% right, because when we go live, things will change again. And you need to be agile to be able to do that. Medical devices. We talk about connecting the medical devices to, assimilate the information from them into the EHR. Sounds really simple. It's not. You need to get on, your clinical engineering colleagues really need to get on top of this. You look at the numbers of devices we're talking about. Each one of these has to be tested and validated to get it in and make sure the data is correct. So again, sounds simple, but it's not that simple. So beware, I suppose. How are you going to integrate other systems? You're not going to replace everything, and we need to do something with the data when we get it. So we started off the process of looking at what systems have we got in the hospital. We thought we'd have maybe about 150 systems, so we started an exercise about 1.5 to 2 years ago. In December 23, we had 754 systems identified. We thought we had 150. We've actually 754 things. Oh, no, go forward March 24, we're now at 824 systems. We're over 900 today. These things come out of the woodwork, right? The laboratory, if any laboratory people in here, you're the worst culprits, okay? By far. Everything, you find loads of stuff. All valid technical solutions that you need to find a solution for, because we're moving into a different environment. So that's a huge piece of work, and if you're looking to get on the EHR train, start now with this, because it takes a long time to go through it. Then you'll get lots and lots of data. You'll be producing loads and loads of reports. It's really good. You can end up, self-service, push the power back to the end user to use this data. But it's not all about the EHR data, and I think some of our speakers have spoken about this. Yes, we have a big cohort of data in the EHR, but we'll be taking data from older systems, legacy systems, I think it was mentioned already, we might want to bring in population data. We might want to do some sort of population management, population planning. So we need an environment outside of the EHR to cope with that system as well. The previous proposals around trusted research environment were also mentioned earlier today. So have you got the training, change and comms sorted, right? Really, really important. Okay, the training is towards the end, but you need to start thinking about it really early on, and the comms, you really need to start thinking about it. We have a simple mantra in CHI: digital first, mobile first, epic first, okay? So we're not really going to tolerate paper anymore. Well, we've nowhere to store it, actually, so it doesn't matter. We're going to try and make all of our users as mobile as we possibly can, and we're going to try and use epic in the first instance where we can. Won't always be the case, but that's what we're going to try and do. You need a good vendor. You need to select a good vendor, and that's to Damien. And his team need to go and select a good vendor that we're all comfortable with. But as I said, there's a lot of good vendors out there. And then you need to link with peers in other sites. And we have been really really happy to engage and take as much information and steal everything we can from a lot of the hospitals you see here. Dermot and his team have been incredibly welcoming, and a lot of my own team have gone up there for various go-lives. And they're going to come down and support ours, aren't you, Dermot? Yeah, thanks very much. Yeah. Is it? So this is really important, because really we're just building on the shoulders of giants. Don't think you know everything. You don't, okay? People who've gone through the process really know where the pain points are, learn from them, and this is incredibly valuable. Start now, start engaging with these hospitals now. Finally, and again Dermot alluded to it, good governance that can move quickly. Okay, that's really what you want. This is kind of some of our governance councils, so it doesn't kind of project very well, and it's only one part of it because we have a whole commissioning program to actually open the hospital, which is way bigger than this. This is only one little bit of that total map. But you need lots and lots of groups to actually design this, configure it, tested, and end users. It's not going to be the 106 people on their own. They're not going to do that. They need the end users. They need the people at the coalface to actually come back and say, that's the right way. This is not working correctly. I need to change that. And then the team will kind of do that. I've robbed this from a good colleague down the back, Adrian Carroll. If you want to know how to put in an EHR, you can grab him for coffee or buy him lunch, even better than that. And Adrian talks about it as being, we're building a house for an EHR. We're not planning to get to the end point where everything is painted and decorated and landscape gardens. We're hoping to get to somewhere here. It's waterproof and it's livable in, and we can keep going from there. Finally, and just in the interest of time, I'd like to say that we think it's all about technology. We think it's all about data. We think it's about us, but it's actually not about us. It's about the patients. Thank you very much.